Welcome to Berlin.
Thank you. Thank you very much, Volker. It's a pleasure to be here at the Congress. I've heard about this event several times over the decades from Volker and from Victoria, and it's great to be here in present today in Berlin. And also good to be back in the city. My first presentation as an academic was at the International Conference on Integrated Care, which was held in Berlin round about 2012. And I presented a poster on new models of domiciliary home care contracting, which went down reasonably, I think. So it's nice to be back here on that purpose as well. But my first visit to Berlin was in 2010 in April. And those of you who are good at dates may remember that was the time of the volcanic ash cloud in Iceland. And my partner and I were delighted that we got to stay an extra few days in Berlin because we couldn't fly home. But reflecting back on coming in 2010 when I arrived yesterday, it struck me that we turned up at the airport and we had no idea what was going on. We literally hadn't heard of volcanic ash cloud. We arrived at the airport, all flights were cancelled, and we thought there must be a mistake, something's wrong here. And I thought today in 2026, we just wouldn't be the case, would it? We're so much more digitally connected, we're so much more aware of what's going on, and there's so many more exciting opportunities that we can get from that in terms of collaborative health and social care and how we work together. The one thing that perhaps hasn't got better is it took me 90 minutes to get through passport yesterday, thanks to Brexit and the new EU system for entry and exit. So some things haven't got better, but it's still great to be here in Berlin today. So, as Volker said, I work at the University of Birmingham, where I'm an applied academic. So I do really love theory, I love conceptual discussion, but for me, what really gets me out of bed in the morning is how can we help people who work in health and social care, whether they're practitioners, whether they're managers, whether they're funders, to do their job better? How do we take evidence and translate that in a way that responds to the real world problems that they face and help them to put their efforts and their skills and their knowledge to improve the lives of people and communities? And that for me is the test of a good theory. Does it translate into real world practice? I've been an academic for about 15 years, but prior to that, I worked in the service as a social worker, as a manager, as a senior leader in health and social care. And I've been involved in the system as a whole for about 40 years because I started as a teenager as a volunteer working with people with learning disabilities who've been discharged from hospital. And I'll bring in my presentation today things from my practice career, from my academic career, and also from my own life as well, my own life experience. And I think it's really important that we try and engage and embrace those different experiences and identities that we have when we try and understand the health and social care system and how we can improve it. So, I've been asked today to focus particularly on collaboration between health and social care. And my guess is that you're all well versed in what healthcare is, so I'm not going to give you a definition of healthcare because that's why you're here. But social care is probably worth talking about because it's not a term that necessarily translates to different parts of the world. Sometimes it's called social care, sometimes it's called social services, sometimes it's called human services, sometimes it's called disability services, sometimes it's called long-term care. Different words, but a very similar group of professions and supports that make up that sector, however you call it and you configure it. And also a very similar set of challenges that those services and those professionals try and respond to. And when I talk about social care, I think there's three main aspects I'm thinking about. So first of all, we're thinking about the professions. And the classic professions in social care are occupational therapy, it's nurses working in residential care homes and nursing homes, but really the focus is often on social work. And social work has different roles and responsibilities in different countries. Often there's an individual clinical basis of trying to support somebody in terms of particular trauma that they've had in their life, of trying to care coordinate services around them and their family, and perhaps also a role in terms of safeguarding, so protecting vulnerable people from abuse or harm. There's also in some systems an emphasis on social work in terms of being thinking about a more of a holistic preventative support for people. And I know in Europe sometimes that's under the basis of social pedagogy, but certainly in the UK and many other countries it's social workers who try to take more of a proactive stance with people. And what's interesting with social work, I think, is that whilst the particular roles and therefore the skills can vary between country and region, what's really the heart of it is a belief in the kind of decency and the human rights of individuals, a commitment to address social injustice and to take a systems view. And whether you're working with an individual person as a social worker or you're taking more of a community-orientated approach or a social pedagogy approach, that's really what you have to be thinking about. And as well as, I think, bringing something to managed care in terms of interprofessional working, I think what social work also brings is a contribution to thinking about how we lead systems. And I often think social workers, what they do is they look at the many parts of somebody's life or the many parts of a system. They are good at thinking about how do we include people in decision making, and they're also reasonably good at conflict, because when you're a social worker you can't avoid difference of opinion, you can't avoid emotional rawness, and that enables social workers, I think, to be good systems leaders, because that's what it's like when you work in collaboration across organisation professions. So first of all, we've got the professions of social work. Secondly, we've got those people who are not formal professionals, so they're not regulated, they don't have to go to university, but actually they provide really important professional support to people on a day-to-day basis. So that could be supporting people in their own home with washing and dressing. It could be helping people to make sure they've got something to eat. It could be helping people to maintain the cleanliness of the home. It could be helping people to go out to external appointments, etc. And whether it's in domiciliary care, residential care, daycare, those people are actually the ones that see somebody on a regular basis, sometimes a daily basis. And if we're going to make managed care that's actually personalised, based around what people want, those workers are absolutely key. And one of the commonalities between different countries, sadly, is that those workers are often not recognised in terms of their status, in terms of their funding, and there's often a lot of difficulty in terms of maintaining that workforce because local populations don't always want to do those roles. So social support is the second part of social care. And the third thing is inclusion. And again, sometimes these are done by multiple parts of the sector, but inclusion is about how do we help people with disabilities, how do we help older people to be present in society. Okay, and a big thing currently is thinking about, salutagenesis or asset-based support. What is it that really matters to people to enable them to have a good quality of life, and who is it that can enable them to connect up with people, individuals, community activities in order to do that? And sometimes that's done by public sector services, but more than often not, it's done by volunteers, by community organisations. And they're sometimes not recognised as being part of the health and social care system, but actually, if you're going to use money effectively and you're going to improve people's quality of life, you have to engage with those organisations and those volunteers as well. As an example of that, my own mother, sadly, has had 3 tumours in recent years. And amazingly, an 82-year-old, she survived them all. She's lost a kidney. She's lost her gallbladder. She's lost her pancreas. She's lost her large intestine. But she's still here. And that's partly due to the amazing skill of the surgeons and the oncology team who supported her through those different times. But it's also because of her friends. It's because of her bridge club. It's because of her other networks that she engages with. That's what gives her hope, what gets her up in the morning, or makes her feel all these battles with her various health conditions have been worth it. And that's what you have to get if you want to have an inclusive society that enables people to have a good quality of life. So, social care incorporates all those things, the professions, the direct support, and the inclusive activities. So why does this matter to managed care? Well, my guess would be that all of you will understand why this manages to managed care. If we're going to think about pathways that enable people to come out of hospital quickly and return to their own home, yes, you need doctors, yes, you need nurses, yes, you need occupational therapists, but you also need people who are going to provide that direct support, are going to help people to get the heating on in their house, to get food in through the door, and to regain their confidence. And that's often not medical professionals or nursing professionals, that's those social care workers who do that activity. Say, if we're going to try and genuinely turn the model of care, so we invest in preventative care, we try to prevent people having crises, we try and reduce people's long-term reliance on services, again, that requires personal and community assets. We have to build on what matters to people, we have to connect them up with others, and we have to encourage them to develop those informal networks. Well, that's what social care does. If we're going to think about inequalities and population health management, thank goodness, is a growing a sort of discipline and focus within health systems. If we're going to really understand which communities do not get access to healthcare, which ones have high levels of obesity, which ones do not get treated properly in terms of employment opportunities, well, again, that's what the social care, and particularly inclusive part of social care, can do. And finally, when the evidence is always tricky with this, because it's hard to evidence the complexity of social and healthcare working together, and it's hard to understand what would happen if you didn't take a preventive approach. But the evidence we have suggests that actually where we do get this integration between health and social care, and we invest the money well, that we can get a reduced use of long-term and expensive services. So the argument then, I think, for why do we need social care along healthcare is not a hard one to make. And it's not been a hard one to make for many decades. And certainly in my own country, where I live currently in England, it was in 1962, yes, 1962, that we had our first national initiative which said we need to bring together hospital care and community health care and social care, which at that point was all run by the local authority. And they said that currently we're not getting the most out of the money that we've got. We have to bring together those different services, and we have to make sure they're planned and organised better. 5 years later, in 1967, there was a big national evaluation, and what they said was that the policy, the legislation, was still not being translated into practice. We were still getting examples of where there was poor join-up between strategic levels of health and social care. We were getting arguments about who was going to pay for what services, and we were getting duplication because sometimes people weren't willing to give up what they did to let somebody else step in. And those lessons are still what we find today when we do evaluations of integrated care initiatives. And in one way you can look at that and say, well, are we actually making progress? But I would look at it on the basis of this is still important, and it shows how hard work it is in order to sustain and embed it. So, a couple of examples of my own work, and I'm going to talk throughout some of the research projects we've been involved with at Birmingham. And when you get the slides, if you click on the link at the top, it'll take you through to the work. So one example that we've been looking at is people with a learning disability who have what's called challenging behaviour. So people who sometimes are aggressive towards themselves, sometimes verbally aggressive or physically aggressive to others. And what often happens to them is when their family or the residential care can't cope, then they get admitted to hospital for treatment, for psychological assessment, for pharmaceutical support, etc. And often when we meet people, we try to say, well, they're going to be there for 6 months or 12 months, and then we'll get them really kind of sorted out, we'll get the medication stable, we'll provide therapy, and we'll get them back home. And sometimes that does happen, but actually what we find is that often that doesn't happen. That as it gets towards the end of somebody's treatment getting completed, it's then very hard to get somebody out. And people can sometimes stay for extra months, extra years, or in some cases decades, because the longer they stay in hospital, sometimes the behaviour starts to unwind. They're on a locked ward with people who've also got sort of communication difficulties and behavioural challenges, and that disrupts their own behaviour, particularly if they also have autism. And so we did a study where we spoke to 30 people who were experiencing this long stay in hospital. And what we found was, first of all, the sort of damaging interaction it had with their own well-being and their own psychology, and the sense of value that they lost because they thought, I can't get out of this place. I'm going to be here indefinitely, and I have no idea what it is that I've got to do in order to be discharged. And what struck us was that the process of going from a hospital setting to a community setting was just so difficult to navigate. And partly this was because the hospital staff didn't communicate well with the community health staff, but actually a lot of it was to do with this health social care divide. So it was partly to do with the money. The money was tied up in the hospitals. That money would have to be transferred to the community in order for people to be supported in their own homes. But that would mean the health service giving money to social services. And they didn't want to do that. It was also about the care providers, and often the staff in the hospitals didn't see care providers as having the skills and the support need to support individuals. And also it was about the social workers' role. And sometimes social workers were very engaged with people in hospital. Sometimes they drifted out because they were there for a number of months. So there was a whole number of factors that each one was perhaps relatively small by itself, but the whole big picture was that people were not able to leave hospital and therefore stayed for many months. And what actually made a difference often with somebody getting out was a key individual. It was a family member, it was a lawyer, it was an advocate, it was a doctor, it was a social worker. There was generally one key person that would get involved and be the difference to somebody staying in hospital or getting in the community. And in one way, that's very admirable. Amazing that people put that energy and that commitment into their work and into making a difference to one person's life. But the other side of that is that not everybody has that special person. And we can't design a health and social care system that's based around a happenstance, that there's somebody in your network who's able to make that difference. It should be much more predicted and consistent between people if it's going to happen. And similarly, we did another study looking at hospital at home, or virtual wards, which again are quite an exciting new development in terms of how do we take acute care from hospital settings, where we know people are at risk of infection, they can lose their independence, they can lose some of the support they get in their environment, and placing in their own home and providing a hospital-level care through diagnostics, through mobile technology, and through mobile doctors and nurses. And virtual wards are very exciting, and we can see they're making a real difference to people's length of stay, to reducing the risk of them going back into hospital, and so on. But we did a study which looked at older people's experiences of virtual wards and their family carers. And again, they were generally really positive about being back in their own home. But one of the major issues they had was that when they came to the end of their virtual ward support, and we wanted to hand over to social care, the boundaries were still there. Whether somebody was physically in a hospital or living in their own home, it was still difficult for them to get social care and social services involved. And so much so that when we did the research study, and remember I'm from a social work background, we couldn't get a single social worker or a single social services manager to speak to us because they just didn't see this as being part of their responsibilities. And again, we're developing these new services, but we're keeping the boundaries that prevent us working together still in place. And then the final thing I would say is that the other part of this is the voluntary and community sector. You know, that has been around usually for longer than the statutory health and social care services or health insurers, etc. Voluntary community sector services can be micro charities working with a particular neighbourhood or small group of people, or they can be massive international global networks. What they have in common is that they care about a particular community. They care about the injustices people face, and they care about the values that they use to support those people. And when we look at integrated care or managed care, you know, many of the things we talk about in terms of being person-centred, in terms of being flexible, in terms of being engaging with people, that's what the voluntary and community sector do on a day-to-day basis. But yet they don't still often get the recognition. And we pulled together a special issue of the International Journal of Integrated Care looking at the contribution of the VCS. And it was incredible to see whether it was homeless people, whether it was people who are migrants, whether it was people with multiple long-term conditions, what difference the VCS made to them. But also the fact that what was commonly reported was they weren't equal partners around the table, they weren't properly funded, they had inconsistencies in their contracts, they had performance measurement approaches that meant they couldn't do the innovative work they wanted to do. So we still haven't got to the point where the voluntary community sector are seen as those equal partnerships, and that's not just within healthcare but also social work as well. So again, a real opportunity there to do things better. So, Volker said I shouldn't just focus on the negative, so I'm not going to do that. But before we finish this bit, why do we still have this? Well, the system factors are important. You know, when we think about why can't we better integrate across acute and community health services, why can't we bring social workers more into this operation as well? Three things people usually say are, first of all, well, it's the IT systems. They just don't join up. We've got a patient record here, a patient record there. We have to write information multiple times. We can't get the data another profession has got on this individual. It's just not coordinated. And fair enough, that is a major issue. The second thing people say is, well, it's to do with the money. we've got our organizational budgets. We're accountable to our particular board or our shareholders. We've got certain things we have to achieve the budget we have, and we haven't got enough money. Everybody's under pressure. We've got changing populations, et cetera, et cetera. Therefore, we can't use the money flexibly, and that stops us doing what we want to do. Yeah, and fair enough, that's important too. And the third thing people will say is, well, the law says we can't do it. The law just stops us working together properly because it loses some of those flexibilities. It prevents us from using money differently. We've got our duties, they've got their duties. The two just can't come together. And again, I would agree, legal barriers are an issue. But what you find is that even where you've got a joined up patient record system that works across health and social care, even where you've got pooled budgets, where you put the money together and it loses identity, even where, like you've got in Scotland, you've got a sort of shared legal framework that says you should collaborate together, that doesn't make the difference on the ground consistently. These are important barriers to remove, but by themselves are not enough. We need to do more if we're going to work together. And what makes that to work together is people working collaboratively. Ultimately, the professionals, the managers, the funders, they have to be willing to use those flexibilities in order to work together better. And a lot of our work at Birmingham has been to try to think about how is it we can support people to collaborate together better. So, as an example of that, I'm going to reflect on a research project we did a few years ago, which looked at what is it that enables or prevents social workers and general practitioners to work together. Now, in the English healthcare system, social workers and doctors are what we call the big dogs, okay? GPs are the big dogs of primary care. The only primary care practices, they are the highest status professional in general practice. But in social care, that's going to be social work. Slightly different, they're usually employed by local authorities, but they're the ones who make the decisions about what support people get. They're the front door that you have to go through to get publicly funded social care support services. So both of those are really important in their particular worlds. And they're supposed to work together better, but they don't always do that. So we did a project where we spoke to groups of GPs, groups of social workers in a similar locality, about what they thought of each other's services, how they work together, and how we could do that differently. So, I've got some questions for you here. Okay, so here's a quote. Well, I'm sure they started out by wanting to help people and do something of value. That's why they must have gone into the job in the first place. So hands up if you think that was GPs saying it about social workers. Okay. Okay. Who thought that was social workers about GPs? Okay, that's quite tentative hands up there, I would say. I think you guys can do better, but that was about 50-50. So that was GPs about social workers, okay? And what that was saying, and this was all the quotes reflect a common themes that we found, was that there's some good bits in that. It's kind of saying, look, I recognize this other professional has got a good set of values that they started with. They did want to make a difference, they were well motivated, but there's also a sadness or a reticence, isn't there, of, yeah, but they're not doing that now. We find that profession, actually, they're quite frustrating to work with. And remember, these are the two key professions in terms of community and primary care, and we don't really see that actually what might motivate them to begin with is still what we find today. So you're starting to get a sense of we're a bit wary about how we work with these people. Okay, so here's the second quote. I'm not sure they always appreciate the power that people perceive them to have. I think there's a massive power imbalance, and I think that's both with families, but also with other professionals. I don't know if they're aware of that. Right, come on, hands up this time. Who thinks that was GPs about social workers? Okay, not a single hand up. Who thinks that was social workers about GPs? Much more hands up there. Yes, you are quite right. That was social workers about GPs. And what's interesting with that is, so social workers have lots of difficult conversations. They speak to families when there's allegations of abuse. They work with the police. They work with broader services arguing for clients. But they said consistently, the person they found hardest to have a discussion with was GPs because they were intimidated by that professional status of general practice. And leading on to that, the GPs didn't feel that was the case. which is really interesting. They didn't think that they had any influence over the social workers at all. And in fact, they would report back to us, but we just can't get social workers to do what we want them to do. They just won't listen to us. And a couple of things in that. So if you don't understand your status, your professional power, then you can't use that positively. And that wasn't recognized by GPs. But also what the social workers and the GPs both did was they try and work around each other. So rather than having a difficult conversation, the GPs would say, well, look, if I think someone should go in a care home and the social worker doesn't agree, what I do is I admit them to hospital, and then the hospital will often then admit someone to a care home. That's just not a good way to do it, is it? We should be able to come together as different disciplines and argue it out, and then come to the best solution for the person with them at the centre of it. Okay, so here we go with the final one. Well, actually, two more. So this one, I'll tell you this one. This was with the GPs, with the social workers. There was a sense that social workers were often not there, often on training. What about this final one then? Very proactive and actually search out people who might need extra care and try and put it in place rather than letting things come to disaster phase. So who thinks that was social workers about GPs? Who thinks that was GPs about social workers? Well, it was actually GPs about themselves. Okay, so and in some ways you can go, well, that's a bit smug, isn't it? That's a bit smug. You're kind of saying how good you are, but you're not recognizing your colleagues. But you know, actually, if you're going to work in collaboration, you've got to be proud of what you want to do. You've got to be proud of your professional identity. And yes, you want to see the good in others, but you've got to go in with a confident attitude of what you can do and what you can add. So I think actually that's a really good status for a profession to have, so long as they recognize the contribution from others. So why have we done this? Well, what we did was because we wanted to understand what was the nature of this relationship that has been at the heart of health and social care for many years, but still doesn't work as effectively as it could. What we thought we'd find is this. We thought we'd find tension and rivalry and conflict, and we found a bit about that. But actually what we found was this. A real distance between them. So GPs didn't really understand, they didn't really understand who social workers were. And when we asked them, have they gone to university? They kind of went, oh, do you know, I'm not very sure. Well, they've all been to university in England, but they didn't know that. When we said, how do you refer to social worker? They said, well, it all gets quite confusing now because we have to go through these different IT systems and online records, etc. And when you asked social workers with GPs, yes, they knew who a GP was, but when we said, well, how are they organised? How are they governed? What does a practice manager do? Again, they just didn't understand. So the actual relationship, which is at the heart of our health and social care system, was very distant, with some exceptions. And the exceptions were always because a GP and a social worker or social work team manager knew each other, put the time in, and were willing to collaborate. Fantastic, but it's not good enough. Okay, we cannot have integrated health and social care, managed care, that is dependent on a few good people working together well. It has to be more consistent. So, as I said, Volker said, I've got to do the positives, so I'm going to do some positives as well. So how can we then help health and social care to work together better? Well, the first thing we can do is, yes, we do need the legal basis. Yes, we do need funding that's flexible. Yes, we do need organizational structures. But what we need to do within those is create space for health and social care professionals to innovate together, because that's where we get the energy, that's when we get the new ways of working, and that's where we get the momentum. And one example of that we've been exploring across the UK is this idea of community hubs, where basically what we do is we recognise that for some people it's quite hard to access health and social care advice, to get guidance, and therefore they sometimes end up going into accident emergency or waiting for referral to social work because they haven't been able to get support at an earlier point. So what we've been looking at is putting in health and social care professionals and the voluntary community organisations in accessible community venues. So those could be in libraries, those could be in sports clubs, those could be in faith centres, either churches, mosques, etc., or they could be in supermarkets. So, for example, there's one big supermarket down in Thurrock where once a month they have a community space that the health and social care professionals can arrive at. And what we found within those is that if you place people in those, or give people that space to occupy, and it could be once a week, once a month, or on a daily basis, and then give them the authority to try and work out how do they engage with the community, how do they make their services more accessible, how do they ensure that people get support at an early point, the professionals will innovate. They'll do things differently. They'll find out new ways to collaborate together. They'll start to identify some of the community gaps, and therefore they'll start to change the way people access practice. And we did a big study looking at how these services are set up and run. And we also did a big data trial of the 30 areas that included those community hubs and the 30 areas that hadn't. And what we found, the ones that have got them have started to change the way we supported people. People were accessing support earlier. They got more coordination in their care packages. And therefore, we can surmise from that that actually they were less dependent on services going forward. So, the second thing we have to do is put more trust and resources in the voluntary and community sector. And I've done a lot of training with what we call commissioners or funders of health and social care services. And when you ask them about the voluntary community sector, what they'll say is, they're really nice people, they're really dedicated, but they're not very professional. They're kind of amateurs in what they do. Well, that's just not the case. That's just not the case. There's many committed skills practitioners, managers, organisations, the voluntary community sector. And so we have to be willing to transfer resources to give them the opportunity and the influence to achieve the change they can. And one example of that we work with is in Northern Ireland, which, as you know, is at the top of Ireland, an area called Mid and East Antrim, which is a rural area outside Belfast. And there's a local organisation there called Mid and East Age Well Partnership. And they start with what matters to older people and how can they make their lives better. And one of the things they found from talking to older people is that they said that, well, when I go and see the GP, or I go and see the social worker, or I go and see the pharmacist, they don't really tell me what's going on. They don't give me ideas of how else I can get support, etc. And so they set up a service, a community navigation service, where a GP or a social worker or pharmacist could contact MIAP, as they're called, and one of their team would go out, they'd speak to the older person, they'd find out what gives them a good life, what have they got in terms of family support, and what else would help. And then from that, they would then connect the person up with voluntary community organisations. And on top of that, what they did was they would bring together representatives from those three service areas, pharmacy, general practice and social work, within a locality to talk about what are we seeing, what are the trends in older people's support needs, what else can we do, and then they would go out to the community sector and say, this is a gap. So family carers of people with dementia, people from minority groups who are experiencing a stroke. This is some of the gaps that we've got. What could you do to support that? And then crucially what they did was they brought in a funding process that if the voluntary community sector saw more older people, they would get funding for that. Because quite often what happens is a voluntary community sector starts doing a new support, they then get deluged by referrals from doctors, nurses, social workers, and then they can't cope with the capacity. So this way, where they were popular, where they're meeting a need, they got funding to follow, therefore they could grow. Third thing we need to do is we need to learn throughout our professional management careers about how to work together. And again, when you speak to health and care professionals, they'll generally say, yeah, we can work together. I know how to collaborate. My problem is that they don't collaborate. They don't listen to me. They don't respond to what I need in order to do my job well. And we found that to some degree with the doctors and the social workers. But actually, collaboration is like any other practice. It's something that we have to constantly reflect on and improve throughout our working lives. And we also have to accept that we don't do it as well as we could do in every situation. So therefore, we have to take on that feedback, that data from others in order to improve what we do. And personally, I would love it if when a doctor has their appraisal, and I don't know how it works in Germany, but in the UK, once you get an appraisal, you get feedback from other colleagues. They should get feedback from people who aren't doctors. They should get feedback from social workers. They should get feedback from voluntary organisations who work in with their kind of populations to understand what they're not doing as well and how they could do that better. Because currently we're so inward facing often in terms of our development, our support. And we set up a program which looked at what we call strength-based leadership. So it looked at practice leaders of health and social care professionals. We brought together social workers, nurses, care home agencies, people from the voluntary and community sector funders to think about how they could be more asset and preventative based in their work. And the learning materials were great, people liked those, but actually what they learned from was getting to know colleagues who were trying to make a difference in understanding their world. And that's what they told us at the end of the program, that's what makes a difference. So we have to learn through our careers. Fourthly, well, we have to think about teams. And all of us can see the logic for bringing together health and social care professionals around common populations. And we know that does make a difference in many cases. particularly around people who've had strokes, people who've got cancer, people with mental health difficulties. But actually what we also find is that we don't always have the right people in teams. We don't have the right leadership for teams, and we don't often have a team culture in which we can address differences and resolve those. So teams are important, but we have to be really clear about why that team with those professionals for that population. And finally, what we need to do throughout all of this is to put people at the center of the care and design of the services and also their own individual care. And whether it's managed care or integrated care, we'll generally say when we do our policy documents and our values that people should be at the heart of what that care is about. But again, time and time again, what we find is that is very rarely the case. We very rarely what we call co-produce with people, communities, and professionals in order to design our services. And we did a project looking at experiences of people who've accessed services across the world who've been seen to try and change services at policy and practice level. And we asked them about what was it that motivated them in order to try and change things. And we found that at the heart of it, there was two stories. One story was care. It was often, I had a bad experience of care, my brother had a bad experience of care, and it just really traumatized me. And actually, I wanted to reflect that back to doctors and nurses and social workers about what that was like. And sometimes it was about I had a good experience of care and wanted to share that too. And there was also stories of change. There was a story of, this just wasn't good enough. I just thought it's just not right that other people should go through what I went through, or my brother went through, my mother went through, and therefore I'm going to try and change and influence that. And what we called those people was citizen leaders. And we said to them, tell us more about how you try and influence health and social care services. And a couple of things on that. First of all, 50% of the people we spoke to who had literally changed things at a national level, set up charities, would say, I'm not a leader. A leader is somebody with power. A leader is somebody with finance. That's not me. I'm not a leader. I'm a patient. Okay? I'm a brother. I'm a sister. I'm a daughter. That's who I am. I'm not a leader. But the other half said, do you know, I never thought about it, but you're right. I'm trying to help health and social care services see a different way forward, have a different vision. Maybe I am a leader in my world. And then we talked about what do you actually do? And the kind of things they do is they build communities. They bring together people who've had similar circumstances and connect them up. They improve services by providing feedback on what matters to people and families and how we can best use resources. They're citizen leaders, this idea of setting a vision and an overall purpose. And finally, some of them are saying that when we're not heard, we're not listened to, we have to disrupt, we have to advocate, we have to stand on the outside, and we have to change services because they're not listening to us. And what we found, again, consistently was no matter where people were in the world, whether it was Europe, whether it was North America, whether it was in Australia, New Zealand, we also spoke to people in the Philippines, that on the whole, people were not supported to have this influence. So we have these values of involvement, and we have these statements of people should be at the heart of care, but we don't invest in them in individuals. We don't give them training. We don't give them encouragement. We don't help them to tell their stories. We often bring them into big audiences and ask them to share very personal details. And what we found was that with a little bit of thought, a little bit of investment, we can actually make a difference. We can actually help people to have a stronger voice and to feel valued and therefore improve what goes forward. And one of the classic things we found was that we say we're going to include people, we're going to have a patient involvement officer, but often they're part-time, often they're badly paid, often their contracts aren't secure. That's not investing in people. That's saying, well, it's a nice to have, but it's not a nice to have, it's a must have. So, I'm going to just finish off in a minute. So I've got one more slide here, and then we're going to share a short video to finish of these wellbeing and operations. So in conclusion, and thank you very much for coming during the lunch break to my talk. So the first thing is healthcare professionals and services will always be at the heart of managed care. And I don't think anybody should have any deny that ever. You know, clinical services are absolutely key to keeping people well and coping with the crises that they face. But to get better outcomes and experience, we have to engage healthcare with wider supports and assets. And social care, whatever you call it, is one of those key opportunities to do that. We have got recognised interventions to support teams, to care coordinate, to pool budgets. What we don't know is how to blend those together. And that will change depending on the context and the situation. And therefore, to do that, we have to learn, we have to be willing to be challenged, and we have to create together. And so to finish, we're going to share a short video of community hubs in action. And there is a longer video you can watch, but here we go.
We offer toddler groups, we offer youth engagement groups for pre-teens, for primary school children.
We've got the libraries here. We've got things like the Fab Lab, so that's like crafts, technology like 3D printing.
We offer bingo sessions, we offer community meals.
We've got our occupational therapy suite.
We have a shop.
But then importantly, we have support services.
So my role in the hub is with the Let's Talk service, which is essentially a pop-up shop for adult social care. You don't need an appointment. You can show up and get advice from us. You know, we can complete assessments of needs with them.
Some of the services that we have available are food bank, citizens advice. We even have Samaritans now that offer a drop-in once a month.
I cook, I clean, I do youth work, I do food bank vouchers, I do everything. So we accommodate everyone. And when you come in, you leave as a friend.
Most of the work that's done here isn't just co-produced with our volunteers, it's conceived and completely produced by our volunteers. But the services that we offer here are primarily a safe, welcoming, familiar space for people to come into.
I enjoy coming, I come and I have my meal. So I enjoy, coming for the bingo and different events and things that happen.
I didn't get involved with the hubs till 15 months ago, and from then it's just escalated to give me this year physical strength, financial stability, all the aids I need to live independently.
I rely on here for social activities. It's really lifeline for me as well.
What we're looking at here is a place where it really is belonging to the people, and they're the ones that should be deciding what goes on, and this is a fantastic example of how that can happen in a local community.
I really, really do appreciate from the bottom of my heart, and I want to say thank you to the library for the things that they do for everyone in Hartlepool.
It's a lifesaver. It's somewhere for them to come and talk to people, and you don't feel on your own. And they make you feel as though you're marvellous,
Okay, thanks very much. And that is the power of health and social care working together. Thank you very much.
Thank you so much, Robin. It was really amazing to follow your talk and to get a deeper understanding. And there were so many things which are striking, and I just want to highlight a couple of them. First of all, I liked very much this picture of a community hub. We had the intense discussion in Germany about Gesundheitskiosk, and it was so distractive. And then you saw the picture and you saw, well, that makes a lot of sense. The same with the film you just showed, which I think is very important in the way how you portray things. Secondly, it was in a sense what you were talking about, technology, which is absolutely important, the question of legal hurdles, but also the question of pooling payments. That's something we have to learn a lot. And again, it was for us, I think it's incredibly important because you see, that's the way how it should be. And the question is, how could we implement it? How could we get it fitting into the existing systems? And we have a couple of minutes time to share thoughts, to ask Robin some more questions in detail. I liked also very much one remark you made, which I think is so fundamental, saying, it's a question of luck having somebody who cares for you. And it does not matter who it is. It could be a friend, it could be a physician, it could be a lawyer. It doesn't matter who it is, but you have to have one person, and that we have to get, in a sense, it more professionalized. So, but again, the floor is open for questions, remarks. How do we get this, in a sense, vision into the healthcare system?
Yeah, and it'd be great to hear ideas, suggestions. Well, in our area, we did something completely different, and this worked, so that'd be great.
Victoria, no, if she would not have raised her hand, I would have asked her. Victoria Stein from Leiden University, one of the leading researchers in population health, and I think it must be exactly what you were expecting, or?
Yeah, absolutely. I mean, we've been collaborating for a long time, so thank you, Robin, for this concise presentation. I would like to pick up on the point you made around when collaboration works, it's down to people knowing each other. And it's not good enough because it doesn't matter whether you're in England, Germany, or Australia. It's still, we've been working on this for 20 years, but it's still down to the chance of previous relationships, knowing each other, liking each other. So how do we get from this chancy setting of it will only work if people actually have a previous existing trusting relationship to a more organized, maybe system approach to have people trusting each other so that they actually can collaborate?
Yeah, no, it's an excellent question, Victoria. And I think a couple of things like that. So one, I do think the legal system, the way that we make people accountable and the way the money flows can help to underline to people that they have to work together. So some people want to work together, we have to make it work together. An example of that is in England, we've got something called the Better Care Fund. Okay, and people will generally say in managed care and integrated care, it's not about top down, it's about bottom up, letting people work together, they're all good people. And they might be good people, but they don't always work together. So in England, what they basically did was they said to healthcare trusts or healthcare commissioners, we're going to take part of your budget, and you're only going to get this part of your budget, say 5% of your budget, if you pull it together with social care. And when you pull it together, you have to use it in this way. You have to help people to leave hospital, you have to support carers, and you have to build up your social care workforce. And if you do that, we'll give you the money, and if you don't do that, we'll keep the money. Well, people were all up in arms, that's ridiculous, how can you do that, you're not trusting us. But they did all do that. They all got the money because they all recognized they had to work together, and it meant they pulled the budgets and they got the experience of doing that. So those kind of levers are important, but it's not enough. We have to be honest. We have to be honest about the fact that professionals don't always work well together. They're not good at collaboration. Okay? They don't always trust others. They sometimes will not express their reservations sufficiently enough. They sometimes don't deal with conflict well. So we have to be honest about that poor level of practice we often find, and therefore when we set up a team or we set up a service, we have to build in opportunities for group reflection. We have to think about training and development for leaders. And currently we go on the basis of they're all good people, if we just put them together, they're going to work together well. But that's just not the case. That's not what happens on a consistent basis. So we have to be more honest about the limitations of people and try and address that, and then perhaps we'll get some consistency.
Another question, yeah. Our colleague from Poland. Please introduce yourself very quickly.
That'd be good.
My name is Paul Zuk, I'm from Poland, and I would like to ask you, Robin, about this trouble we have in our system, that the medical staff really don't want to share the medical data for the social workers. And this is the trouble, because some of this data are crucial to give a good quality of care for these people. So how you solve this problem in a Britain way?
Yeah, so that's a really important point. And I think we can, and I always think with these kind of situations is that there's probably two different aspects to look at it. One way is you can say, they're just being difficult, they're trying to hold on to their professional status, they're trying to hold on to their empire, which might be the case, but alongside that, they may genuinely have some reservations about, people have shared this with me as a clinician, have I got their authority to share with it, will it be used responsibly? So I think you have to always see that there's not just one motivation of people saying no to that. I think that's really important. In terms of addressing it, I think you have to, there's a couple of things. One, I do think a legal basis has to be there. That has to be in place. I think we have to kind of share the vision of why it's important, but also in terms of getting people to actually do it, what can be quite helpful is to say to them, what is it that makes your job difficult? What is it that stops you doing what you want to do? And sometimes you can find that they've got pinch points, which will then, by sharing data, you can help them to overcome some of the day-to-day challenges that they are facing and they see as growing. So something about saying to people, ethically this is the right thing to do, legally you've got a duty, but actually on a personal, professional basis to do your job well, you have to share this as well. On top of that, I think you have to get the professional bodies behind it. really, because one thing you'd have to see is really strong with doctors is that sense of being an independent clinician who's part of this guild of other clinicians with a similar background. And when you start to get the professional bodies saying, actually, from our point of view, good practice would dictate that we share data responsibly with people's consent, then it starts to change the benchmark for what's expected. So, and you'll know this, there's not one way of doing it, but you have to get that professional support, you have to get the kind of legal duties, and you also have to say to people, actually, your life will be easier if you do this. So, combination.
So also, in other words, in a sense, physician shortage, etc., are the best things which could happen to the system because people have to start to share resources and working together.
Well, that's right. So, I mean, a crisis can go either way, can't it? It can be a momentum for change because you disrupt the status quo, or it can be something that just becomes more negative. People become more inward-facing, and actually you lose some of the good work that you've got. And COVID, I mean, COVID was obviously a terrible thing, but I hear over and over again people saying that, you know, COVID was the best of times, was the worst of times and the best of times, because actually in COVID, people were willing to drop some of those professional hierarchies. There was authority for them to use resources flexibly, and they believed in the voluntary and community sector. And now people are often, when we speak to them, are mourning a loss of that shared sense of vision that they had during COVID. So obviously, none of us want a pandemic again, but that belief, and the thing is, when you look at kind of long-term care needs rising, multiple conditions, all the rest of it, we have got a thing of pandemic proportions, but it's just burning slowly over time, and we're not recognizing as being that crucial.
And how could we provide evidence that this is not only good, but also a business case? How could we make the studies, how could we deliver the proof that it's not, in a sense, just something we believe is in favor, but it's also, in a sense, from a system perspective, call it business model or whatever. Because we see, when you look at integrated care systems in the US who are very business-driven, they look very much at these kind of things. They're very open for that.
Yeah, well, they do, and they should be. I mean, they've got a responsibility to use their funding well. So they've got, I mean, I don't think it's unreasonable to say, if we're going to invest this amount of money, then, you know, are we going to get a good return on it? It's obviously complicated to evaluate these things because there's often not just one intervention, there's multiple interventions. You get big contextual differences between the kind of general environment. Certainly in the UK, we just have one raft of policies after another. So before one's settled in, another one's come in, so it's hard to differentiate. But there's also something about, I guess, research is as biased as healthcare service delivery. So the research infrastructure in healthcare, particularly hospital care, is much stronger than it is in community, in social services, in the voluntary and community sector. So again, when we start to embrace new partners, researchers often don't really understand what those partners do. They don't often have the data infrastructure they need to get those particular metrics from them. So there's something about building up our research capacity and moving money from healthcare research into social care research and voluntary and community sector research, so we've got that. And there's also just something about, I guess, us having a shared idea of what is it we want to achieve, because again, that's often an issue in terms of what is this program going to develop. So it is complicated, but I think we can do it, and we've got some of the big examples we've got in the UK. It's interesting is, what we don't find, Volker, so much is that hospital admissions go down. What happens is that hospital admissions stop rising as much. So if you start off on the basis of we're going to integrate care, less older people go to hospital, you might be frustrated. If you say we will say we'll start to stop that trend, then you might feel actually we're getting somewhere. So something of being realistic what we're asking for. And the other thing with the business case, I think, is that when we do a business case for managed care, integrated care, we sort of forget how much money we've tied up in business as usual, and are we getting value from that? So we say, well, we'll ask people to care coordinate, but only if you can prove that works. But we're living with a system which is fragmented. It doesn't communicate with people well, it's not joined up, and there's loads of negatives about that. You know, the amount of kind of missed appointments people have, or the waste that we suffer, or the damage people have to put right because our system doesn't work currently. We don't seem to say, we need to address that, and actually how does our business case help us to do that? We always look for added value.
You mentioned the figure 1962 for the first report. What should be the first step for the German government, in a sense, going this path? What would you recommend them? Where should we, in a sense, start? Because it's a long journey.
So I think the first thing is you do need policymakers to articulate that this broader social care sector is really important, and healthcare cannot do its job properly unless it's collaborating. I think there has to be a really strong policy statement about that. I think you do need to make sure that the legislation takes down the barriers. It won't actively enable people to work together, but you can stop some of the rationale people give for we can never make this happen. So you have to do that. And then I think you do have to think about some of the kind of performance metrics and put in place, it's not just about hospital activity or general practice activity, it's about some shared outcomes. And then you have to be able to give people the space to do it. And I think that's where they could start. And politicians can't change practice, but politicians can set the environment which encourages people that it's possible.
What a fantastic finishing sentence. And I like the way how you portrayed it, Register Now. The International Conference of Integrated Care, in a couple of months, they expect 1,500 participants. If you get a sense, in a sense, how exciting this topic is, this is the place to go. And Robin, thank you so much again. It was a wonderful speech.
Thank you very much.